Okay, so I think the microphone is working. So welcome everybody to this symposium organized by Terumo. It's my pleasure and honor to co-chair this session with Professor Mamas, that everybody knows, and also Professor Stankovic, founder of the EBC. Today, we are going to talk about the Ultimaster Nagomi multi-center registry. It is we are all here in the steering committee of this multi-center registry, which intend to include 3,000 patients with highly complex PCI, and including also bifurcation stenting and complex lesions. There will be a 2 years follow-up, and today Professor Stankovic will tell us about some preliminary data about bifurcation lesion from this large multi-center registry. So Goran, please.
Yeah, thank you. Thank you, Adel. Good afternoon, everyone. It's a long day, but I think presenting data from complex patient and lesion subset is always exciting. We are always looking forward and continuously trying to check the change in practice. And you will see we are doing better. This is the talk about bifurcation subset from the NAGOMI complex. And as Adel said, NAGOMI complex post-market clinical follow-up study will enroll 3,000 patients who will be followed for 2 years at least. These are complex characteristics, long lesions, left main, every left main, severe calcification, multi-vessel disease, 2 or more vessels, 3 or more lesions, complex bifurcations, chronic total occlusion since entry stenosis. In addition to primary endpoint, that will be 1 year rate of target lesion failure, which is cardiac death, target lesion-related myocardial infarction, or clinically driven target lesion revascularization. We will also have patient-reported outcomes, quality of life and angina status, and there are 2 predefined dedicated subsets that we especially expect new data that may help us change the practice. High bleeding risk patients and bifurcation lesions with independent core lab. Currently, there is more than 1,500 patients included in the registry, and at the time when we did this analysis, it was mid-2024. Total population that was extracted at that moment in June was 1,078 patients. We split the total population in no bifurcation lesion or bifurcation lesion at the index procedure. So 188 patients had bifurcation lesion treated at the index procedure, and there is small difference to 142 patients for whom either bifurcation lesions that were treated did not meet criteria for complexity, or QCA data is still not finalized. So please take all this as a very preliminary, but I think very important and very interesting data set. We had 43% of patients older than 75 and 53% of patients meeting high bleeding risk criteria. When we speak about clinical indication, 3/4 had chronic coronary syndrome and 1/4 acute coronary syndrome. And if you see the division, it was mainly 73% non-STEMI, 20% angina, unstable angina, and only 6% STEMI patients. These are the data on lesion and procedural characteristics. Radial access, 90%, that is really current practice. Number of lesions, 1.8. Number of stents per subject, 1.9. Per lesion imaging, whether it's IVUS or OFDI, 44.4%, so we can do better. Especially this is left main and this is complex bifurcations, but this was, I think, slightly better, 10% more than EBC main and DK crash 5. So we are improving, but slowly. Post-dilatation, which means optimization of stent expansion, 94%, And we are happy to have 37% left main bifurcation treated. And in that subset of left main, mean syntax score was 26.5. If we look the distribution of lesion location, LAD was the most common bifurcation, 47.5. As I said, left main 37%, circumflex 12%, and right coronary only 4%. And very importantly, complex lesions type B2 or C were present in 80% of those lesions. We are happy that 345 Nagomi stents that were implanted in bifurcations during this index procedure were successfully implanted in 99% of cases. And as I said, in 198 bifurcations, 44.4% imaging is better than before, but we can still do better. Importantly, 2/3 of the lesions were complex through bifurcations. 111, 46.5%, 13% 011, and 1015, 5%. Among non-true bifurcations, 110 was the most prevalent with 22%. And I think this is the key, how we changed the practice from previous platforms in the Ultimaster registry now to NAGOMI COMPLEX. First, you remember we published from the Ultimaster registry 33% rate of POT, and that translated in clinical benefit in population who actually had proximal optimization. Now we double that rate. It's 70% of patients with POT, which is, I think, significantly better. So our club meetings, consensus documents, and discussions at every meeting resulted in really improvement in the current practice. Final kissing balloon, this is polluted, single stent and two stents, 57% final kissing balloon inflation. Single stent, 55%, two stents, 45%. Imaging, as I said, per patient, 46 versus 54, no imaging. But if we split this in a single stent versus two stents, we see really that POT is stable, 70% in both, re-POT 30%, and kissing balloon in provisional expected 26%. I don't expect higher rate because there is also many non-left main bifurcations. If we speak about two stents, then POT again 72%, and kissing 91%. This was confusing in report of EBC main, so in two-stent strategy, we really routinely perform kissing. It's better to be higher, but 91% is again better than it was before. If we go to the technique that is used, you can see down that culotte again and T-stenting are the most frequently utilized, which also reflects Rolex registry as well as EBC main crash in 16% of cases. And clinical outcome, we have so far only 1 month follow-up data. In green, it's bifurcation. The rest is in orange. So numerically, definitely higher event rate for bifurcations, including patient or clinical endpoint, 4.3, 2.8%, target lesion failure 3.2, double compared to non-bifurcations. But in general, there is no significance, mainly because these are small numbers and this is still preliminary analysis. And if we split again in single stent versus two stents, we see the same. In red, it's single stent, really almost half of the events compared to two-stent strategy in every category. So definitely single stent replicates data from Rolex and EBC main, and really shows significantly lower rate of clinical events. So this is all so far from the preliminary presentation, and I'll be happy to answer any question that you may have.
Thank you very much. Thank you very much, Goran, for this very nice overview of this preliminary data. So almost more than 30% of bifurcation without a POT, so still ABC has a lot of task to do in the future, because it's still amazing that cannot imagine a left main or a complex bifurcation without pot, so it's amazing. Not even a single pot, I mean, registered in this. So let's see what will. So this reflect real-world practice, and as you said, in Ultimaster it was only 30%.
Only 30%,
yeah, so,
and that translated in clinical benefit if you do pot. So I think now we have convincing evidence that doing pot is really helpful for major clinical outcome data. And this, to be honest, I was very happy when I saw 70% because I remember 33% and now we are at 70. Next one, I don't know when you are planning the next platform, I expect 91, so I think then we'll be happy.
Thank you very much. Maybe without delay, maybe we can move directly to the case presentation from Professor Mamas, who is going to show a nice case that we can discuss all together. And if I'm not wrong, was included in the registry, huh? Professor Mamas, yeah, sure.
I think it was before we were allowed to include STEMI cases into the registry. So if we can, great. So over the next 10 minutes or so, we'll have the case presentation. So this is quite a complex case in terms of decision making. And it was really a man in his late 60s. And this is a guy who came in with VF requiring 3 shocks in the ED department. He had transient ST elevation. We got him into the cath lab, then had further VF arrests and again, several shocks. Now, he was complex in terms of his comorbidities in that he was known to have Behçet's disease, but also had rheumatoid arthritis with significant vasculitic involvement. So he had peripheral vascular disease and also biopsy documented vasculitis, and also required anticoagulation on the basis of his atrial fibrillation. So this is a guy who clinically is complex, but is also high bleeding risk because we know atrial fibrillation and rheumatoid arthritis are high bleeding risk states. And if we can play, no, wait a minute, just go back. Can we play the video, please? Play the video. Play the video. Okay, if you play the video before. So I wired both vessels. You can see that he had an osteal lesion in his LAD. This, I think, is after I pre-dilated the lesion. I think the first lesion you'll see was a pin-tight lesion. Just go back to the very first, go back, back. Okay, there, play the video. Okay, so I used the balloon, pre-dilated, play the video. This is after pre-dilation, great. So this is what we've got. And then I IVUS, so if you play the IVUS, click the play button. There you go. So you can see the IVUS here. So you can see this is in the LAD going backwards, some calcification. This is after pre-dilation. It's a large vessel. You can now see the ostium of the LAD. And you can see now going into left main. And you can see from the IVUS catheter that there's really quite significant disease in the left main. So even though on the angiogram it looks like the disease is mainly limited in the ostium of the LAD, you can see from the IVUS exam that you've got quite significant plaque burden in the left main. Now, the other complex aspect of this is the diameter of the left main. So this is one measurement, it's 6.6 millimeters, but even further down, it was around 6.2 millimeters. So this is a big left main. Oops. And so I guess my first question is, what's the strategy here? We've stabilized the situation, we've pre-dilated, we've had an IVUS. The IVUS shows significant disease in the ostium, extending into left main. We've got a big left main, 6 millimeters. Adel, what do we think?
Yeah, very, very interesting learning from this case. So first of all, we have left main, which is probably can be labeled as not super complex, because, for example, on the side branch, there is some lesion on the circumflex, which is not extending a lot towards the proximal circumflex. So my first question to the audience will be, who would go here for a provisional strategy here? Who in the audience will go for provisional in this case? Raise your hand. Okay. Who would go for a two-stent technique? Who? Almost no one. Okay,
Who would nail the ostium? Because you've got a massive left main here. So who would try to position the stent into the ostium of the LAD?
I think no one. Okay.
No one.
The second important question. So who will do this case without imaging? So raise your hand. Who will do actually imaging in this case? I think we have seen in the previous presentation, for example, for calcified lesion, what we can get, what you can extract from intravascular imaging, like, for example, the amount of calcium and so on. But I think for left main, one of the most important aspects of imaging is the sizing. The sizing. Angiographically, you cannot expect, for example, that you have 6 millimeter, 5 millimeter or less. So it's super important that when you do a left main, you do a perfect job, that you oppose the stent proximally in the right way and so on. And probably that's what you have done here. The second thing is the platform. Which one? So that you are going to develop, Manas.
Well, I guess that's obvious. It's a Terumo Symposium, so I'm not going to show a Boston platform. But I guess, this was... this was up front. So, in my lab, we have many platforms, but my decision making for using the Ultimaster platform for this case is, first and foremost, there was a significant size mismatch between the LAD and the left main. And really, when you're looking at platforms that can expand beyond 6 millimeters, there's only, effectively the Ultimaster and the Giant Sierra that go above 6 millimeters platform. So I opted to go for the Ultimaster. The reason I opted to go for the Ultimaster is a high bleeding risk patients. We've got data from MasterDapt for high bleeding risk patients and complex PCI. That data's been published. And also the 10 crown design. And I think that's really good for left mains in that you get much better apposition, much better coverage, much better drug delivery. We know that patients with left main are high bleeding risk. This is data from Mount Sinai. I understand Aleid Kieffer is also currently preparing and presenting some work around her registry. But over half of patients undergoing PCI for left main are high bleeding risk, as was my case. So play the videos, please. So I deployed the Nagomi 4x21 millimeter stent. And then next, let's have a look. Okay, and then I potted with a 6 by 8 millimeter balloon. What do you think happened? Well, you can see what happened. So you can see that I potted with the 6 millimeter balloon, inflated at high pressure. Just play that second video again, please, on the right-hand side. Yep. So you can see I've now compromised the circumflex ostium. So what do we do? I mean, we've now got a situation where we've done something that we think is going to be straightforward and we've compromised the ostium. So why do we think it's happened and what do we do about it?
So I think first of all, the angle is extremely a narrow angle that probably favors the carina shift towards the circumflex and worsen actually the lesion at the ostium of the circumflex. The second thing is the balloon that you have used. We have seen in the EBC consensus document the positioning of the balloon when you do the pot at the level of the carina is extremely important. I think your markers are at the right spot. Probably you're a little bit too distal, but also the shoulder of the balloon are looking a little bit too large. So probably that also favor the shift of the carina towards the circ in this case. So that I think that can happen. But I think the angle was also something that favored the carina shift here, I think, towards the circumflex.
I mean, I think the main problem here, if you look at the inflated balloon, look where the markers are and look where the balloon is. I mean, it's really interesting that, I mean, it looks as though it's an 8 millimeter balloon, but the balloon's extending at least another 8 millimeters further ahead. And so I think, in these very short, large balloons, you really have a big problem with that. And I think, the pot balloon that Brosmed are releasing overcomes this problem in that the expansion is very near the markers and you don't have this huge balloon extending way beyond the markers. And I think that's really one of the problems in this case that we had. So I then rewired and used a 4x15 Trek final kissing balloon in both the LAD and the circumflex. Kissed, and you can see that there, positioning the balloons, do the kiss, and looks okay-ish. And then I, again, do the pot, but this time be slightly more careful and bring it slightly further back from where the markers suggest that you should be going, given my experience already. And this is the final result. So you can see this is a huge left main, and the circumflex looks reasonable. It's not compromised. And this is the IVUS. Again, you shouldn't be doing these cases without IVUS imaging. You can see in the LAD, going back, you can start seeing the stent. It's well opposed in the LAD. It's a 4mm platform, and you can see that it's now gone into the left main. It's well opposed, and I think it's a reasonable result, so good expansion in the left main. What antithrombotic regime are people going to use? Maybe, I mean, you've seen the case, so I'm not going to ask you. Maybe I can ask people of the audience. I mean, you know, you've got a left main, a big left main. You've got someone who's anticoagulated. You've got someone with an ACS who's had an out-of-hospital arrest, who's got rheumatoid arthritis with Behçet's disease and biopsy-proven vasculitic process. What regime are you going to use? How long for? I mean, he's got AF as well. Are you going to use an anticoagulant? How long?
Hello. Yeah, so I think you've got to monitor. The bleeding is going to come from your non-steroidals. They're going to erode the stomach. They're going to start the bleeding, and then obviously your anticoagulants are going to then make the bleeding not stop. So if you can eliminate the Disprin, you'll give them Plavix, and whichever NOAC you want to give him for the
how long atrial fib. And so you've got a complex left. Well, I mean, you've got a left main. How long are you going to give the Plavix for?
At least 6 months, but I would try and stretch it even longer, 9 months.
How about everybody else? Anybody go shorter than 6 months? Anyone giving 12
Let's
months?
ask the audience, who will give to this patient 6 months of clopidogrel? 6 months, only 6 months. Okay, me also. Who will go for 1 year? Okay, so still not clear. But the high bleeding risk patient, I think the stent is well opposed, so probably no risk of at least restenosis, thrombosis, probably with the new platform. And also you will show data also that we have with this platform.
3 months.
Yeah.
How about 1 month?
Oops.
1 month. 1 month of combination only. Yeah. Okay.
So I guess one of the things that we have data is we have data from the MASTERDAPT trial. So this was patients treated with the Ultimaster platform. Patients, there was an OAC arm and a non-OAC arm, and patients with high bleeding risk were randomized to abbreviated versus standard approach. You can see that in the complex versus non-complex PCI group, there was no interaction. So irrespective of complexity, short DAPT in these patients. The music's playing, so that means I'm overrunning. It's great Star Wars music. And what do the guidelines say? So the guidelines say, up to 6 months if it's high bleeding risk. I think in this case, I did use 6 months of dual antithrombotic, but I agree. I think in retrospect, I probably could have gone down to 3 months. I think that's reasonably safe. Particularly if you've used IVUS imaging, and particularly given this was a big stent that was well opposed. I mean, this is a 6mm in the left main, 4mm in the LAD. And so I think when you're doing these sorts of cases, to me, you've got to think about the expansion properties of the stent. And I think in this sort of case, there's very few platforms that could go comfortably above 6mm. I think the fact that it was a high bleeding risk case, again, I think there's very few platforms that have data in this subgroup, or only one platform for abbreviated DAPT in high bleeding risk for complex PCI. I think if you're going to do these cases, you shouldn't be doing them without intracoronary imaging. And I think, short DAPT with NOAC monotherapy after 6 months, I think is a reasonable approach, but I probably would agree that you can probably shorten it down to 3 months, and I don't think it would have made much difference here. So, hand back to you.
Thank you very much, Dr. Mamas. It was a very nice demonstration of a complex combination of a complex setting, anatomical setting, and high bleeding risk patient. I think we still lack a trial with patient with high bleeding risk randomized, because the master adapt was a sub-study of the whole population. So we still need one randomized comparison of patient when we do a complex PCI who are high bleeding risk, when you can go for abbreviated therapy as compared to a standard therapy. We still need this trial to upgrade the guidelines for showing the safety of an abbreviated therapy. Also interesting to acknowledge that in master adapt, the single antiplatelet therapy in the abbreviated group was mostly clopidogrel. So I don't know if people will go for only aspirin after a short trial of DAPT. So I think also I think those stents are becoming safer and safer. And see, as our colleagues said, we can go for 3 months, 1 month sometimes if we have to stop the treatment for any reason, for surgery. We feel more and more confident with those platforms, especially if you have done a good job, good apposition, good treatment at the index procedure. That's also very important to allow to shorten the DAPT or the antitraumatic regimen. So thank you very much to all, and Professor Mamas and Goran for
That's nice to see.